This is Mohamed A Yassin, and I'm going to present one of the unmet needs in chronic myeloid leukemia. It's the association of tuberculosis in patients with chronic myeloid leukemia. This is a treatment proposal based on literature review. So tuberculosis, both active and reactivation of latent TB remains the most common infectious disease worldwide and leads to high mortality. Currently, 1/4 of the global populations has been infected by Mycobacterium tuberculosis. The incidence of TB has been reportedly increasing in patients with cancer. It has been mostly found in an association with non-Hodgkin lymphoma and chronic lymphocytic leukemia. Active tuberculosis refers to the disease that occurs in someone infected with Mycobacterium tuberculosis. It is characterized by signs or symptoms of active disease or both, and is distinct from latent TB infection, which occurs without signs or symptoms of active disease. Active tuberculosis case finding. Active case finding is synonymous with systematic screening for active TB, although it normally implies screening that is implemented outside of health facilities. Passive tuberculosis case finding. This is a patient-initiated pathway to TB diagnosis, and it involves one of 4 categories. The first one is a person with active TB experiencing symptoms that he or she recognizes as serious. The second category is the person having access to and seeking care and presenting spontaneously at an appropriate health facility. The third category is a health care worker correctly assessing that the person fulfills the criteria for suspected TB. And the fourth category is the successful use of diagnostic algorithm with sufficient sensitivity and specificity to diagnose TB. Passive case finding may involve an element of systematic screening if the identification of people with suspected TB is done systematically for all people seeking care in health facility or clinic. Frequently, we are hearing the term of latent tuberculosis or latent TB or LTBI. So what do we mean by that? Latent tuberculosis infection is defined as a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigens without evidence of clinically manifested active tuberculosis disease. Individuals with latent TB infection represent a reservoir for active TB cases. The detection and management of LTBI is now a key component of the WHO and TB strategy. This is because with latent TB infection can progress to active TB or undergo reactivation, a risk that is greatly increased in those with immunocompromised conditions. What about CML and TB? Recently, the incidence increased in patients with chronic myeloid leukemia during treatment with imatinib. During treatment with imatinib has also been reported in a retrospective cohort study in Taiwan by Louis CJ et al. And few other published cases in the literature. This might be due to impairment of the T lymphocyte signal transduction, leading to increased host susceptibility to TB, hepatitis B, and varicella zoster infection. And the other dimension of the problem, the treatment of tuberculosis in patients with chronic myeloid leukemia, representing a treatment challenge, or you can call it a treatment dilemma, for many reasons. The first of these reasons is tuberculosis infection in chronic myeloid leukemia patients creates a dilemma for treatment due to alteration in the pharmacokinetics of tyrosine kinase inhibitors by anti-TB medication. This aspect poses a challenge to active clinical remission in CML patient, as well as proper TB treatment. Inadequate treatment in such clinical scenarios increases the risk of mortality in this category of patients. Currently, there is a lack of clinical guidelines to provide a solution in such condition. Based on keen literature review, we propose that both conditions can be treated with adjustment of tyrosine kinase inhibitors dosage or anti-TB medication classes switch based on clinical remission and cautious patient follow-up. TB screening is also mandated in special cases of CML patients in order to provide optimum management for cure purpose. Our view is based on previous literature search, and clinical recommendations need further randomized clinical trials if it is feasible, and research study in order to support this kind of evidence. What about screening for TB? A total of 33% of the world population is considered to have a latent TB infection. Worldwide, TB screening is performed either by tuberculin skin test, the TST, by purified protein derivative, PPD, or interferon gamma release assay test, IGRA. The Center for Disease Control and Prevention and the United States TB screening guidelines endorse the use of IGRA test in place of MAN2 test, as it needs only one visit to take to the blood sample, rapid availability of the result in 24 to 48 hours, and there is no cross-reactivity with the vaccinated PCG antigens. What about the lines of therapy? Usually, classically, we are talking about two lines of therapy. The first line, anti-TB medications, and the second line, anti-TB medication. The first line anti-TB medication consists of 4 medications: isoniazid, rifampicin, pyrazinamide, and ethambutol. The first 2 medications, isoniazid and rifampicin, both of them, they are bactericidals, and both of them, they inhibit mycolic acid synthesis in mycobacteria. What about the drug interactions, which is important to us in case of TKI? Both isoniazid and rifampicin, they have a drug interaction, and in the case of isoniazid, there is inhibition of hepatic cytochrome enzyme system, CYP 450. And in the case of rifampicin, also there is an drug interaction because it induces hepatic cytochrome enzyme system. And what about the adverse event? What about the hepatotoxicity, which is a likely complication? Hepatotoxicity can happen in both isoniazid and rifampicin, and in addition to that, in isoniazid can cause additional side effects like peripheral neuropathy, neuropsychiatric changes like seizure, euphoria, insomnia, irritability. And rifampicin can cause other side effects in addition to hepatotoxicity, like flu-like symptoms, hemolysis, skin reactions, glucose intolerance. What about pyrazinamide? and ethambutol. Pyrazinamide is a bactericidal which inhibits fatty acid synthesis in bacteria, and it's not known to cause, or maybe there is less studies. Also, it's a hepatotoxic, and it can cause drug fever, hyperuricemia, and non-gouty arthritis. Ethambutol, it inhibits synthesis of Mycobacterium tuberculosis, as well as other component. And it's not known to cause or less studies about the drug interactions. It decreased the visual acuity and rarely can cause optic neuritis and peripheral neuropathy and hypothyroidism. What about the second line anti-TB? In the second line medications, we have the streptomycin. Streptomycin was previously considered as first line and may still be used with first line medications as per requirement. Due to increased resistance previously to these drugs, many parts of the world has decreased its usage. The other second lines are fluoroquinolones, levofloxacin, moxifloxacin, and amikacin, kanamycin. All these groups of medications are reserved for a special situation as in drug tolerance or resistance. So what we learn from the literature? We have to touch base on several of these studies. One of them is the retrospective nationwide cohort study in Taiwanese population. It was conducted by Liu Seiji et al., and where he and his group conducted a large retrospective nationwide cohort study in Taiwanese population over 14 years that highlighted the incidence of TB. And we mean by TB here, intrapulmonary, extrapulmonary, and active as well as reactivation in CML patient. In this study, 1,082 CML patients taken from the National Health Insurance database were matched with 10,820 non-CML cohort. The incidence of TB was observed in both arms of the study with a significantly increased risk of TB in CML patients with a p-value more than 0.001 and adjusted hazard ratio of 3.76. The authors highlighted the fact that immunocompromised status have a higher risk for developing TB infection, especially with hematopoietic stem cell transplantation, owing to its nature of impairing cell-mediated immunity, association of TB and CML. However, even without hematopoietic stem cell transplant, CML patients are at risk of developing TB infection compared to the general populations. They found no association of increased TB incidence with tyrosine kinase inhibitor therapy in CML patients during the study. Concomitant TB infection increased the mortality in CML patients with a p-value equal of 0.043. This study was conducted with a large sample size over a significant period, and reporting TB cases was reliable and adequate in Taiwan because of the physician's legal obligation to report TB cases, including the death within 1 week to the CDC. This study has described an important association between two diseases, CML and TB. It also suggested treatment strategy in such circumstances by increasing the imatinib dose to 50% from the baseline due to CYP34 enzyme induction by rifampicin. However, this report has some limitations. The first one, patients' baseline characteristics were not matched and analyzed during the study. It is well known that the socioeconomic status, smoking history, quantitative analysis of the PCR genes, and performance status of the patients are important in assessing the risk of TB. Furthermore, patients who had TB with CML were not examined for reactivation or new incidence of tuberculosis. Finally, it is a retrospective cohort study in a selected group of patients from Taiwan. Another investigator from India performed a prospective cohort study in 1,100 CML patients, where he and his group analyzed data in a selected group of patients with previous TB infection and followed them as a primary outcome of the study for development of an active TB. 21 patients out of total had a history of TB infection, both intrapulmonary and extrapulmonary tuberculosis, during a median follow-up of 49 months. 3 patients on imatinib treatment developed active tuberculosis, but no TB reactivation cases were reported. The mean duration of TB infection was 17 months from the initiation of imatinib therapy. This study raised the possibility of dysregulated cell-mediated immunity due to imatinib therapy leading to TB infection. Later, the patients were commenced on anti-TB medications for 6 months with an increased dose of imatinib due to the interaction of rifampicin, a potent inducer of cytochrome P450 enzymes. During the follow-up, no adverse events or side effects were reported, and molecular remission was observed. This study has described an important association between the two diseases. It also suggests a treatment strategy in such circumstances by increasing imatinib dose to 50% from baseline due to cytochrome P34 enzyme induction by rifampicin. However, this report has some limitation because patients' baseline characteristics were not matched and analyzed during the study. It is well known that socioeconomic status, smoking history, and quantitative analysis and performance may affect assessing the risk of TB. This study has been conducted in India, where the chance of getting infected with TB is high, and it's higher in patients with CML patients, and it has described the 2 most important points in relation to CML patients. First, that there is a higher risk of getting active TB in CML patients being treated with imatinib therapy, and secondly, the need of increasing the dose of imatinib while or rifampicin-based medications. Besides the prospective nature of the study, the sample size was adequate and patients received an effective follow-up. However, the study was not an RCT. Therefore, medical management and disease correlation lack of internal validity and generalizability. Nevertheless, it has opened a window for conducting more studies and trials to validate the outcome of patients. Daniels et al. Describe the correlation of increased incidence of TB in CML. 3 CML patients on imatinib therapy were followed for more than a year for the development of TB. 2 patients developed intrapulmonary TB, while an extrapulmonary TB of the spine was found in 1 patient. These findings were reflected based upon the rationale of imatinib-mediated disruption of the T receptor signal transduction against antigens, leading to defective T-cell mediated immunity and increased risk of infections like tuberculosis hepatitis B, and varicella zoster virus. What about TKI interaction and dose adjustment with anti-TB treatment based on the case reports and case series? Several case reports in the literature have mentioned different treatment strategy when encountering TB in CML patient. Simultaneous administration of rifampicin-based anti-TB therapy leads to decreased plasma concentration of dasatinib or imatinib in CML patient. Therefore, dose escalation was preferred until molecular remission was seen in these patients. Another preferred option was to treat such patients with isoniazid, moxifloxacin, ethambutol, and pyrazinamide. However, these case reports and case series have a weak evidence because of shared personal experience based on individual patients, responses in absence of validated guidelines. What about the treatment strategy of concomitant TB infection in CML patients based on a single-centered study design? A single-centered and single-design sequence study was conducted in 40 healthy subjects to observe the pharmacokinetics while prescribing imatinib with rifampicin. The concomitant administration of cytochrome P33A inducers and imatinib resulted in a subtherapeutic plasma level of imatinib. Therefore, it has been advisable to use non-rifampicin-based anti-TB drugs like fluoroquinolone without much interaction with imatinib. Another option is to increase the dose of TKIs by 50% minimum from baseline, or switching to different TKIs class with a better tolerability profile and target to achieve hematological remission. To the best of our knowledge, there are no randomized control trials or FDA-approved guidelines to treat concomitant TB infection in CML patient. Therefore, a clear strategy to deal with such clinical conditions is lacking. The immediate treatment for the concomitant disease has been suggested based on the clinical experience and clinical response of some patients published in a few case reports, case series, retrospective studies. After careful reviewing of the literature, we put forward our treatment suggestions accordingly. These proposals for treatment needs further research studies and a dedicated randomized control trials to develop a clear and adequate treatment guidelines. The final goal is to address the concomitant TB infection in CML patient and to improve the quality care and to reduce the morbidity and mortality. So this is the first algorithm, which is algorithm for initial screening and treatment of CML patients having risk of active or latent TB infection. And here we defined what is called as the high-risk patients. Who are the high-risk patients? High-risk patients are defined patients in the endemic areas of TB or having underlying immunosuppressive status like transplant patients, diabetic, end-stage renal failure, chronic obstructive pulmonary disease, HIV, and malignancy, or immunosuppressive medications like those receiving corticosteroids or other chemotherapeutic agents, or IV drug abusers or alcoholism. So if the patient is diagnosed with CML, then you can do TB screening with PBD or IGRA, which is recommended, but we put the both tests based on the availability because in certain countries there is no IGRA, so PBD is more commonly available. For high-risk patient, you do the screening, and then if the test is negative, then commence the patient on TKI therapy, monitor patient typical symptoms of cough, fever, lymphadenopathy that raise the suspicion of TB. And in the other scenario, if any of the tests positive, do chest X-ray. If the chest X-ray has no cavity or signs of active TB, then proceed with treatment of latent TB. The second algorithm is algorithm for treatment with tyrosine kinase inhibitors, imatinib or dasatinib, with anti-TB medication. And here what we do, if the patient is diagnosed with CML on TKI therapy, to be started on anti-TB treatment for latent TB infection or active TB, and then we can go either to increase the dose of TKI from baseline to at least 50% until molecular remission, or to follow patients for molecular remission and treatment adherence. Or in the other scenario, we can switch to non-rifampicin-based anti-TB therapy with the same dose of tyrosine kinase inhibitor. And to conclude, we can say that anti-TB medications possess interactions with the various other drugs and TKI therapy by altering the liver cytochromes enzyme system, affecting the metabolism. It has been seen in CML patients when commenced on TKI therapy, thus creating a challenge for treating post-disease. In conclusion, we propose that CML patient diagnosed with TB infection, either pulmonary or extrapulmonary, during treatment on imatinib or dasatinib, and requirability increasing the dose of imatinib or dasatinib therapy to 50% from baseline, or patient can be kept on the same dose of imatinib dasatinib with non-rifampicin-based anti-TB prophylaxis. Rifampicin-based anti-TB medications can be used, but with caution, as we mentioned. Furthermore, if CML patients treated with imatinib, dasatinib, or anti-TB medications with a dose adjustment of TKI or non-rifampicin-based anti-TB therapy do not achieve molecular remission during the follow-up, we suggest a genetic mutation studies or to consider different TKI therapy class other than imatinib or dasatinib. We also propose to screen CML patients having a high likelihood of suspected TB or risk of developing TB during the course of treatment, especially in patients from an endemic regions and having other disease compromising their immunity, like diabetes, alcoholism, or corticosteroids. Either PBD or IGRA test can be performed. Early diagnosis, prompt management of TB infections are crucial in such patients and in such clinical scenario, and we aim to help the medical community to address and manage this dilemma of concurrent TB infection in CML patient through this presentation. These are the literature which we have been reviewed. And if you want to access our full review and you have more insight about this topic, you can review it in the expert review of hematology. And at the end of this presentation, I would like to acknowledge all my colleagues who supported me to come with this proposal. I would like to acknowledge also my wife and my family, the International CML Foundation, for giving me the chance to present this work to our CML community, and also to all my mentors and supervisors, as well as to all my lovely patients. Thank you very much.